Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. For this episode of the Interventional Glaucoma podcast, host Professor Ike Ahmed presents a series of Elios case studies recorded by Dr. Anna Miguel, Dr. Jose Belda, Mr. Karl Mercieca, and Ms. Nishani Amerasinghe during ESCRS 2024. Let's listen in.
Well, welcome to our next episode of the IG podcast. My name is Ike Ahmed from Toronto, Ontario, and Salt Lake City, Utah. And here we're going to talk about cases in interventional glaucoma. You know, we've talked a lot about some of the theory behind interventional glaucoma. We talked about some of the treatment options in interventional glaucoma, the rationale, some of the outcomes and results. But there's nothing better to us as clinicians to use cases to highlight the considerations, the approaches, and the outcomes that we may have using MIGS and using interventional glaucoma procedures in real patient populations. So today we have four excellent international collaborators that I'll be introducing throughout the program here that will highlight, you know, where they've used Elios and where they've used MIGS procedures in their glaucoma patients. To start off, I have one of my former fellows, the very enthusiastic, originally from Portugal, now in France, Anna Miguel, who's going to present an interesting case of where she's used Elios and MIGS procedures in her patients. So we're going to start with Anna. Over to you, Anna, to start the ball rolling in our case discussions.
I want to present a 56-year-old patient with very high intolerance to eye drops. He had a pulmonary emphysema, so he could not tolerate beta blockers. He had an extremely important dyspnea and irregular compliance. He even felt that his prostaglandins worsened his dyspnea, but he did not tolerate any other eye drop class. He had a mild primary open-angle glaucoma, and he was under eye drops for 10 years. Very severe hyperemia and some eczema of the eyelids. He had a visually significant cataract with visual acuity of 4/10, and he was really bothered in his life. I proposed phaco Elios because I thought this would be a very good candidate to try to get off the eye drops, to improve his life quality, and to try to be one step ahead of his disease and control his disease earlier. He was hospitalized for his lungs, and I had to postpone his surgery. When the surgery was done, in terms of body and body position, it was difficult. So this technique was very useful because I was able to do the surgery fast, and everything went well. After surgery, I had a minor IOP spike due to the steroids. I decreased the steroids, and at 1 month, he had an IOP of 10, and at 6 months, he has an IOP of 11 on 0 classes. Before surgery, he had IOP of 25 on 1 class and very poorly tolerated. It's a great example in terms of quality of life. He has now white eyes, regular eyes. He's very happy, and he's actually waiting for the left eye to have some cataract more to start.
Well, that was a great case that Anna shared, and this is kind of a great example about our treatment goals will vary patient to patient. And this example here, although medications would likely be helpful in lowering the pressure, this patient was quite intolerant and had contraindications and had poor compliance here with the topical medications. And we often say that cataract surgery is a great opportunity to address some of these issues. The procedure itself, as Anna's mentioned, is quite amenable to different conditions. Because of his short learning curve and his flexibility, allows us to do these procedures fairly efficiently using Elios and placing 10 openings in the nasal quadrant typically. The outcome, of course, is fantastic. And this is not uncommon where, medications lead to a vicious cycle where patients take the medications, it doesn't work well for them, there's contraindications, there's intolerance, there's hyperemia, and that itself potentially sometimes leads to, pressure fluctuations and other issues as well. So it's really a great outcome. I think it was important for this patient likely to set the right treatment goals, with the goals being to really reduce medication load, to address the intolerance of medications and reach a more stable pressure. I particularly find in these cases of mild glaucoma that we have a bit more liberty in terms of what we can tolerate pressure-wise and have a higher chance of getting patients off their drops. And this really has been done and shown quite nicely by Anna. This also gives us, an opportunity if down the road a patient needs something that, the eye will be quite receptive to doing something else, potentially bleb related or minimally invasive, bleb surgery. So, great example, a great result, and, a really classic example of using cataract surgery to not only address the patient's vision, but to address the issues with regards to glaucoma drops. And now we have Jose Belda, my friend from Spain, presenting his case.
I want to share one of the latest patients I've been, I have treated with Elios. This is a patient that works in a pharmacy. He owns a pharmacy. He's a pharmaceutical. And he wanted to have, when he came to the clinic and we were discussing about the different options to treat his glaucoma by surgery, because he also has a cataract. He was obviously going for cataract surgery. And he wanted to have something done for the glaucoma as well. So I explained him the different options. And when we talk about Elios, he was quite fond about having Elios because something came out. Because I told him, well, we're going to do laser. Laser is, well, something that we normally do in ophthalmology. We have lasers for everything. This is like the world of the galaxies. We're using lasers for almost any pathology that we treat. But this time, the patient told me something that really impacted me. I don't want to have anything inside my eye. I want something that will leave my eye like it is, or better. So when I explained him other options, he knew that we had to put an implant, and this was implantless. So he was very happy about having Elios. Saying that, he had a pigmentary glaucoma with a cataract. So surgery went totally uneventful. I removed the cataract. I did the treatment with Elios in the inferior nasal angle, and I managed to do 10 microchannels. There was a very mild bleeding of one of the microchannels, but it was not worrying because I could manage to clean it during the surgery. And on the post-op period, I removed all the medication. He was on a combination. If I remember well, it was a beta blocker and a prostaglandin. And the base pressure before the surgery was 23. After the surgery, 1 month after the surgery, and with no treatment at all, the pressure went down to 14, which is excellent. There were no complications, and the patient is extremely happy, not only because of the Elios, of course, but also because his vision has improved because of the cataract surgery.
Yeah, well, that was a great case, Jose. Thank you for sharing that. Sounds like this patient was quite informed, which our patients often are. As patients, sounds like they're a pharmacist, so very attuned to the different, medical options at least. Again, going to cataract surgery allows for the opportunity to address the glaucoma at the same time. And I think I often say, this is a one-time opportunity to be able to address glaucoma at the time of cataract surgery, and want to take advantage of it with something that's going to result in, minimal impact to the cataract outcomes, but the ability to improve quality of life and improve glaucoma outcomes as well. There are so many options now in MIGS that are available. It is confusing, and not only for patients, but also for clinicians. How do we decide to do one versus the other? And there's no one size fits all, of course. But this particular patient sounds like, what resonated with this patient was the fact that, quote unquote, they wish to leave the eye as it is without any type of implant. Now, I am certainly not opposed to implants, and I certainly use implants for glaucoma surgery, but I think that, for some patients and some clinicians, this is an appeal. And I think that's certainly well reasonable considering the outcomes we can get with Elios, and, the feeling of a laser, a natural, treatment is appealing to patients. Pigment dispersion is one of those diseases that is probably more proximal in terms of the immediate issues that manifest with pigment-related, outflow facility reduction. And so the idea of bypassing it with channels is appealing. Infranasal quadrant that Jose mentioned is a good target. We feel that that's where the capacity is maybe increased with our collector channels. and the patient had a great outcome. We often, debate whether we should continue medications right away after surgery or not. This case, the patient had mild disease with a couple classes with IOP that was low 20s, reasonable to stop it. Expect sometime the patient may get a bit of a pressure spike for steroids, so something to watch for. But this patient had a great outcome. Now, I probably wouldn't have, given the patient a guarantee that they'd be off their drops. The factor 23 on two classes. I would have said my goal is to reduce the pressure. Number one, my goal is to reduce the medications. And if I can, really, achieve all of it, it may be able to be off the medications. So far, a great result and a great example about, patient selection, procedure selection, and how to manage, medications after surgery. So thank you, Jose, for sharing that case. All right. Well, our next speaker is my friend Karl Mercieca, international man of mystery, now in Germany, and looking forward to hearing his case.
I do a lot of combined surgeries with MIGS. So, phaco MIGS. Usually older people who come for the cataract surgery are on drops. You've got that one in a lifetime chance. You're in the eye. You do something extra. Try and get them off those drops. Try and lower their pressure. So combined surgeries are the mainstay when I use MIGS devices. But the first Elios patient I had was not old. She was in her 40s, just like me. A young lady who had ocular hypertension, not glaucoma, but a very strong family history of glaucoma. So her dad and her granddad had glaucoma. And her pressure was high, above 24 when diagnosed with ocular hypertension. Put on numerous drops, but couldn't tolerate any of them. She then had SLT, which nowadays is our first line to go to, but unfortunately didn't work in her case. So we know that 80% of SLT works, 20% doesn't. So she's in the 20% group. And she read about me. So she came to Bonn to ask about the options of standalone MIGS. And of course, we know there are different MIGS options. So I went through all of them with her. She didn't want a foreign body to stay in her eye. Discussing all the other options which would perhaps dilate the channels, the canals, cut through trabecular meshwork, or an Elios. The idea of Elios was very, very attractive to her and to me. Why to her? Because it seemed that it was a clean procedure. It was an option where there was less invasiveness in a way, because you're not going in with any form of foreign body breaking tissues or expanding tissues, and you certainly weren't cutting tissue with, of course, the inflammation that comes with any wounds we create in our bodies. And for me as well, there were the attractions that I was going to use a device that is very easy to handle, that is very precise. So we listed this lady for right eye phaco, Elios without phaco, because she had a clear lens, she had clear vision. Did it in 5 minutes, topical anesthesia, bit of myocol to make sure the pupil was small, to make sure that the lens is protected. So I would definitely recommend that if it's a standalone case. Viscoelastic, viscous enough to make sure there's enough space in the eye, push the lens back, push the iris back, and deliver a safe laser. She had one eye done first. I actually saw her the next day because it was my first case. So whenever you adopt a new device, you want to see the patient a little bit more until you get more experience. Next day, pressure was 12, minimal hyphema, minimal. Vision was 612, pressure was 12. So I said, stop your drops. She was still on one drop with a pressure of around 21 pre-op, okay? Which definitely wasn't good enough for her. I saw her a week later. The pressure was still 12, off her drops. Her vision was 6.6. So we listed her for the other eye. Within 2 weeks, same, no hyphema. Vision was actually 6.9 the next day. Pressure 11, 1 week later, off drops. So this lady now is 6.7. Well, now she's more. So she's probably a year now into her surgery, and she's still off drops. So we saw her a few weeks ago, still very happy, still off drops, let's see what the future brings. But now she's in her early 40s. You know, if she does develop glaucoma in the future, I still have all the options available. I can do anything I want. So she's happy, I'm happy. And yeah, that's my first Elios case out of all the others I've done since. I know that many of us combine phaco with MIGS, but we must also think that standalone procedures are important to have. It's always easier if patients are pseudophakic. It just gives you a little bit more of serenity, especially if it's a training case. But also, phakic patients can benefit from an excimer laser, which again, you know, is a very commonly used type of technology, which has proven to be very safe, very precise.
Well, that's great, Karl. Thanks for sharing that. I love this case because it's obviously a little bit of an atypical case, and it brings out a lot of interesting points to discuss. As you mentioned, Karl, you know, this is not a classic case of MIGS, which is often combined with cataract in older patients. This patient was young, ocular hypertension, and this is a standalone procedure. Someone who's intolerant to medications here as well. And, you know, one thing I do want to mention is the SLT, because I think there's some, you know, confusion perhaps. SLT and excimer laser Elios, these are certainly both laser platforms, but they both lower pressure, but by different mechanisms. SLT, you know, we of course debate the mechanism, likely a biological turnover with some underlying low-grade inflammation induced by the laser that enhances outflow facility, but doesn't actually create an opening. Excimer laser obviously removes or ablates tissue to create these discrete 200 micron openings throughout the canal. So different mechanisms in terms of achieving that outcome, and likely, I say likely here, a more durable option with excimer laser, and some studies have shown that comparing these two head to head. Now, standalone MIGS to me is a real, you know, blue sky for us. It's a real open field that I think is emerging here as opportunities to use MIGS. Obviously, the considerations are a little bit different. The emphasis for pressure lowering is paramount here, and so I like Elios in the sense of being able to provide a larger span of treatments over a larger area of the angle. One thing that's very important, and again, we could talk about pseudophakic and phakic patients. Pseudophakic, we have a bit more liberty with not worrying about cataract development. What I worry about most in these young patients is cataract development. I want to be able to go in the eye. I like the idea of miotic, not touching the lens, protecting the lens, and go in efficiently. We don't want to be in the eye for a long time. We don't want to be continuing to add OVD. We don't want a lot of bleeding. We want to be in and out of the eye. That reduces the risk of cataract formation. And Elios is certainly very amenable to that. What I really like about the ability to be in and out, which I think is very important. I think that, you know, of course, we think about interventional glaucoma in doing things earlier, before secondary disease occurs beyond the canal, before the disease becomes more irreversible in terms of outflow morphological changes. And although this patient doesn't necessarily have glaucoma, they have ocular hypertension, to me, this is the ideal patient to best benefit from a technique like, you know, MIGS, because we still need to rely on the pliability, on the reversibility of disease, and we have to rely on the fact that the outflow system beyond the canal is still intact. And it is likely to be more intact in a younger patient with early glaucoma or ocular hypertension than somebody who has very chronic disease over a long period of time with more advanced disease. Probably the outflow system is more shocked there and the success rate may be less. Indeed, the result here, 1 year later, fantastic result. And I think this is a great example about showing this. Now, is it ahead of its time? Perhaps. Maybe we should be doing, well, we are doing SLT first line now. Interesting, SLT is much more effective first line than it is when it's third or fourth line for the same reason I mentioned. Should we be doing MIGS early on in the patient journey before these problems occur in the outflow system? This is a great example of that. Maybe we should, but really a good example to make us think about the role of MIGS early, the role of Elios here, the role of standalone and differentiating from SLT. So really a great example from Karl, and pretty bold that with this being his first Elios case, choosing this patient, which of course is a testament to the man's skills. Well, our next case is presented by none other than my good friend Nishani from the UK, and she's got an interesting case to present.
I'm going to present a case of an 86-year-old gentleman who had primary open-angle glaucoma. He'd also had multiple other health issues, including heart failure and lung cancer. In 2004, he had undergone a right trabeculectomy and mitomycin C in another centre and had prolonged hypotony, which required a bleb revision. This has obviously required multiple follow-ups. And when he was seen again, this had obviously meant that he'd required multiple follow-ups. He was referred to me in 2018, and his pressures in his left eye were out of control with a progressing visual field. At the time, his examination showed that his visual acuity was 6/18 in the right eye and 6/9 in the left. He had this large cystic bleb overhanging with pressures of 9 millimeters in the right eye and 23 in the left. Corneal thicknesses were on the thinner side at 534 microns in the right eye and 540 microns in the left. He was a bilateral pseudophakic and had advanced glaucomatous optic neuropathy in the right eye with a cup-to-disc ratio of 0.9 and infratemporal thinning in the left eye with a cup-to-disc ratio of 0.75. Field testing showed a superior and temporal defect in the right eye with an ND of -16.08 and a superior defect in the left eye with an ND of -0.12 decibels. OCT scanning showed a marked retinal nerve fiber layer loss in the right eye and inferior loss in the left. So the patient and their family were very unkeen for him to have a trabeculectomy, understandably looking at his history. They felt his life expectancy was not great, and so having discussed this, we actually opted for a microstent MIGS procedure. This was successful in lowering the pressure in the left eye to the mid-teens, and the patient remained stable for many years. However, last year, the patient's IOP returned to 23 on maximal treatment, so another conversation regarding surgical intervention was had. The usual path would be to go for a trabeculectomy. However, the patient had done well to survive his lung cancer, but was increasingly frail. So we needed to think about some sort of intervention that didn't require multiple follow-ups, was safe and effective to do. And therefore we discussed the Elios procedure. Because of its precise nature with no collateral damage, I felt it would be an excellent choice to work around the 2 failed microstents. We knew that the TM bypass had worked in the past with a microstent, so why would it not with Elios? And the beauty of the Elios is working over a larger area, and there would be no collateral damage near the microstents. The patient underwent an Elios procedure in March of this year, with 10 shots being placed adjacent and between the 2 failed microstents. This brought the pressure down to 14 initially, and we were actually able to take the patient off the dorzolamide drops he was taking. And at the last examination, 5 months post-operatively, the patient's IOP was 16 on a combination drop of bimatoprost timolol, so only 1 drop a day. Patient and and his family are delighted.
That's a great outcome, Nishani, and again another case that is not conventional, but makes us think about where MIGS fits, and I love it. Obviously, this patient's an older patient with multiple medical issues and has had a difficult course in the first eye, although it sounds like a necessary course to get the pressure down to where it was after trabeculectomy. And the choice of going to MIGS as the first surgical procedure a few years ago seems to have borne fruit for at least a few years. The idea of what to do once a MIGS procedure has already been done, in this case, microstents, and where the IOP has now gotten out of control, which is what happens in glaucoma, as we know, disease progresses. I don't know if I would say the surgery per se failed. I would say the disease progressed rather than necessarily the surgery is not working, but now we need to do something more is an important question. I think the majority of the community would certainly have thought, well, we've tried MIGS already once. We need to go now beyond MIGS and go to a bleb and maybe choose a MIBS or choose a TRAB or something else perhaps. But I think Nishani brings up some really good questions again, or really good points. If it worked the first time, why not try again? There was a good outcome that lasted for many years. We also understand and know the anatomy and physiology of the outflow system is somewhat segmental. If the stents were placed in one area, then perhaps there's other areas which may still potentially be able to be innervated to improve pressure control and reduce resistance. The flexibility of a procedure is also important. I think this is where Elios comes in. The ability to put these very well discreetly placed channels anywhere we want in the canal adds a lot of versatility and flexibility to the procedure. We can use, for example, a double mirror lens we can place the openings anywhere we want in the eye. It can be temporal, infratemporal, infranasal, around the previously placed MIGS procedures. And I think that's what Nishani was able to do. And that's a real versatile approach to using these MIGS procedures. So, in summary, MIGS after MIGS, we certainly need more evidence, need more data on this. There are some reports out there, and this is a great case example that we need to think about. Certainly with the disease level not being severe, it gives us the opportunity to, again, go back to a more less invasive procedure, saving our big guns for later if we need to. Life expectancy also plays a role in this decision as well. But I like the thinking here of MIGS after MIGS, especially because it worked for a while. I think in some ways it's kind of like SLT in the sense that why not we repeat it until it doesn't work as one way to consider it. But even more so, this allows us to do these bypass procedures in other areas where we haven't touched yet, which is what the benefit of an Elios procedure can be after these MIGS options. So again, this is a great case to highlight a different aspect of using MIGS and Elios after MIGS procedures. And it gives me certainly ideas to put together some more studies to look at this and evaluate this in a more robust manner, which was great. Fantastic. Well, we've heard 4 very interesting, very different cases with different treatment goals and different patient populations. I want to thank all my contributors here. We've had great cases, from Anna, from Jose, from Karl, and finally from Nishani to give us a real good thought about what the role of MIGS in glaucoma is, and specifically with Elios. I hope we've been able to review what our treatment goals will be. Obviously, combining cataract surgery is typically the entry point for surgeons and patients to think about MIGS, with treatment goals being both lowering pressure and addressing medication intolerance, which is a very important aspect of glaucoma treatment. We can't minimize the quality of life issues that our patients feel, and the benefit of adding MIGS to cataract surgery, building upon the pressure lowering of phaco and the predictability and the refractive and the postoperative efficiency of phaco allows us to combine MIGS procedures quite well. Elios adapts very well to this, with a short learning curve and ability to provide a larger area of treatment and do it in a way that maybe, as some of we've heard earlier, a more natural way, leaving the eye fairly untouched. I love the last 2 cases of standalone procedures where we rethink about the role of MIGS, whether it's really early in treatment, where we need to do something more, but we tried SLT. We don't want to necessarily go to a bleb procedure, but we're not happy with the medical therapy. I like using MIGS early. I think that the chance of success is higher. And then the other side of it, someone who's older, someone who's had previous MIGS treatments already, where there's an opportunity to do something beyond what we've done with the first MIGS procedure. So as I often say, MIGS after MIGS. So again, great chance for discussion. I hope it's given all of us a chance to think about where we use MIGS and where we use Elios. And our journey continues to do better for our patients and what MIGS and these technologies have brought to us. So thank you all for listening to this podcast, and we look forward to much more discussion and much more ability to help our patients. Thank you.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLAs GmbH, and the FIDO laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.